Welcome to the show discussing problems and issues of health with Dr. Alcena. For this segment of the show, I'm going to continue to talk about sickle cell disease. Sickle cell disease is a very common disease throughout the world. Worldwide, there are 300 million folk with sickle cell trait. And in this country, you have 3,600,000 folk with sickle cell trait and 100,000 people with sickle cell disease. It's very common. It's a bad disease. It causes a tremendous amount of pain and misery for folks who are affected. The three main genes that are responsible for this sickle cell disease are BAN from Benin, CA from Central Republic of Africa, and SEN for Senegal. Those are the three genes. Okay, and this disease were brought into the New World from Africa, and then it's here. It's a multiracial, even though most folk associate sickle cell disease with black folks. It's multiracial. For instance, in this country, 8% of Latinos have carried the sickle cell trait. The same percentage is true in black, 8%. There you have it. So, and then throughout the world, most folks who are dark-skinned, who for their own ethnic reason refuse to pass themselves as black folks, but when one were to examine their DNA, you will find that there's a tremendous amount of sickling disease among them as well, and a whole host of other abnormal hemoglobin diseases that are all associated with people of immediate African ancestry. Case closed. If you don't want somebody to know exactly from whence you came, you keep your blood away from them, because if you don't, and they get access to it and they get your permission, you're going to find out stuff that you wish you hadn't discovered. For whatever reason that folks found it negative to be associated with blackness, I found that completely hard to comprehend. But again, I'm not a psychiatrist nor a psychologist. These are people's mind, whatever it is. Be that as it may, the last time I spoke about management of sickle cell disease in the hospital on the emergency room setting. In this segment, I'm going to start talking about the treatment of sickle cell disease in an outpatient office setting. Most folks who have sickle cell disease, obviously, they hemolyze. And about those with SS, which is the homozygous, about 65% of the red blood cells are hemolyzing. They have 30 to 35% normal red blood cell. Okay, and as the red blood cell hemolyze, they dump massive amount of pigment in the bloodstream, which leads to a lot of pigment disease such as gallstone, etc. All you have to do is have sickle cell disease and live long enough, you're going to have your gallbladder taken out surgically sooner or later. That's just the way it is. They form what's called bilirubin stone, and they have gallstone disease with all its complications thereof. So the hemolysis is the main disease that they were born with. Because of the hemolysis, they, as part of it, I should say, see these malformed cells that are banana-shaped and half-moon shaped. They clogged up the blood vessel, the tiniest little vessel, medium-sized vessel, or what have you. And that's an ischemic occlusive disease. The clogging up of the cell caused them to develop ischemia, and the ischemia caused them to have pain. So pain is the second symptom that one associates frequently with sickle cell disease. Okay, now in the office setting, we manage these individuals by, first of all, checking the red blood cell count to see how low the hematocrit is or is not. The hemoglobin is not. It is very important to understand that you do not want to raise the individual hemoglobin or hematocrit too high. You would like to keep the hematocrit somewhere in the neighborhood of 25, 27, 28, 29%, in that range. And the reason for that is because blood is very thick. Because blood is very thick, the blood is likely to clog up the vessel themselves, resulting in what we call total organs ischemia, and this is a disaster. Because the blood is so viscous, we like to keep the individual hematocrit level somewhere around 28, 29, 27 all the time. Now, if we have to transfuse them for acute reason because they're hemolyzing, they're very sick, we be very careful not to raise the hematocrit above 34%. Let me repeat that. Because if you raise the hematocrit above 34%, because of the viscosity of the blood, you're making the situation worse, and you're basically endangering the different organs in the person's body. And because the underlying vessels are so bad, they've been damaged over the years because of the sickling phenomena, which itself causes inflammation, which leads to plaque formation. So these individuals have plaque formation disease in their arterial as well. So now the vessels are bad. So the tensile strength of the vessels are bad. So when you add a viscous material such as blood to it, can't handle it. Absolutely cannot handle it. So they're going to wind up with a stroke. They're going to have an acute heart attack. See, these things are things you have to pay close attention. Last week I mentioned during the show the importance of paying close attention to what people call minutia. Well, this is one of them. Okay? You will say, well, the person is hemolyzing, you give them as much blood as possible. That's not true. Because on the one hand, if the blood is too low, it's bad for them. The red blood is too low. If it's too high, it's bad for them as well. Because ordinarily, an adult man, hematocrit can be as high as 50%. From 42 to 50%. That's considered normal. Well, you can't raise someone who's sickling hematocrit to that level without causing them to have total organ failure because of ischemia. Can't do it because of the viscosity of the blood. That's not minutia. That's just knowing how to practice clinical hematology, clinical medicine. The thing that came to my mind as I was going home last week, is that I should have given you folks an example to think so that you could keep that in your back pocket, something that's happening as I speak. Let me deviate a little bit. One of the most common problems, complication in an intensive care unit in this country and throughout the world is bleeding. You say, well, how come bleeding is so common? I want you to envision somebody who was very sick. They may have had major operations, either brain surgery, back surgery, bowel surgery, chest surgery, major problem. They have tubes all over the place. And they develop some sort of an infection, which is reasonably common. They put them on antibiotics. This is the right thing to do. Well, this is the point. They're not eating. They're on antibiotics. Okay? We say, well, what relationship does that have to do with bleeding? Why there's so much bleeding in the intensive care unit? Well, here's the reason. The reason is there's a vitamin called vitamin K that we take in our food. 90% of the vitamin K that we need to remain vitamin K balance is taken from the food that we eat, the fruits, the vegetables, etc. Here's the deal. They're not eating, so they're not getting that 90%. I said, well, what's the problem here? Well, the problem is 10% of vitamin K in all human beings are made in the large bowel through the action of bacteria in the bowel, 10%. And you need that 10% to remain in balance, okay? So now they're not eating. Some of them, a week, 2 weeks, they're not eating. They're getting intravenous IV fluid or whatever. And then they're on antibiotics. So what's going to happen to that 10% of vitamin K that is to be produced in the bowel? It's not being produced because the antibiotic is wiping it out, wiping the bacteria out. There aren't enough bacteria in the bowel to produce that 10%. So now you have somebody with severe vitamin K deficiency. And out of the blue, they start bleeding. How about that? You don't even realize how many phone calls over the 37 years that I've been in practice that I had to respond to go to the intensive care unit. Somebody's bleeding. The question, is it a surgical bleeding because they're going to take the patient back to the OR. That's pretty drastic stuff, because you have a sick patient going back to the OR for general anesthesia to try to find out why they're bleeding, when in fact, most of the time they're bleeding because they're vitamin K deficient. It's that simple. You say, well, why don't folks think about that? I have nothing to do with that. I have nothing to do with that. I didn't teach these people medicine. I had nothing to do with it. I have taught medicine for 42 years. 5 years while I was in training, I was teaching students and intern below me, whatever, and 37 years in practice. 42 years I've been teaching medicine. I have no idea why these people didn't, nobody taught them this, or if they did, how they managed to forget something so important. It is not minutia. It's crucial, because somebody is bleeding can cause them to drop their blood pressure, go into shock, and all the rest of it, for something as simple as not realizing that they need 10 milligrams of vitamin K once a week. That's enough. That was solve the problem. Once a week, everybody who is in the intensive care unit that's getting antibiotic, that's not eating, should get 10 milligrams of vitamin K intravenously. Simple as that. If you don't, you're asking for trouble. Bleeding is going to develop, okay? So that's not minutia. I just wanted to give you that example so that I forget to mention that last week when I tell you the stuff that's going on, that you got all these high-power specialists, and some of them are indeed very good at what they do, but they're not going to pay attention to somebody's vitamin K level. Okay, they're going to stick the tube in and make you breathe better and do all this great stuff that they do, but how about a little bit of vitamin K? That will solve, that doesn't cost millions of dollars. It doesn't cost thousands of dollars. It's very cheap, and it's going to save the patient from bleeding. Okay, now let's get back to sickle cell anemia. Yes, so you don't want to raise the hematocrit too high. You want it to keep somewhere around 27, 28. So that's one way we manage them. The next thing we do is that we prophylax them with penicillin if they're not allergic to it, 250 milligrams 4 times a day for life. Or if they're allergic, we give them erythromycin, 250 milligrams 4 times a day. We say, what's the purpose of that? Well, these individuals, especially those with SS disease, have no spleen, because the sickling phenomena auto-destroy the spleen over the years. So they are asplenic. And the spleen is a very important organ that supports part of the immune system, and that when bacteria invades the bloodstream for one reason or another, it doesn't have to be in the bloodstream, it's somewhere in the body, you have an infection. The spleen, first of all, these individuals have a propensity of getting infected with capsular medications such as pneumococci, bacteria such as pneumococci. So the spleen is needed to attack, they secrete some stuff, some enzyme that help to dissolve the capsid within which these cells are contained, so that then the antibiotic can get at them and kill them. That is also the reason why, in addition to give them the antibiotic, we also give them pneumovax. Every 3 years, we give them a vaccination of pneumovax. And that pneumovax vaccine is efficient against several, maybe 18, 19, I don't remember the number anymore, of different organisms associated with this family of bacteria. Okay? So that's very important. So you give them pneumovax every 3 years. You prophylax them with antibiotic every day. You're taking care of the infection part. The next thing you're doing to keep them from the hospital, you give them folic acid. Now we're talking about maintenance in the office. How much folic acid? The human being requires 400 micrograms of folic acid per day. The body, in a normal setting, in a normal individual, is not made to absorb more than 400 micrograms of folic acid per day, even though the common dose is 1 milligram that is produced. But for nutritional purposes, you give them a milligram, you know they're going to absorb 400 micrograms out of it. 1 milligram is 1,000 microgram, but not somebody who is hemolyzing. You say, well, how so? Well, every individual who are hemolyzing, all of them, no matter the reason, are folate deficient. The reason is because folic acid is very labile. It stays in the human body maximum 7 to 10 days. If you don't take folic acid for 7 to 10 days, you are already folate deficient. That's been proven through research. Unfortunately, the gentleman who did this very beautiful research passed away several years ago. He trained at Montefiore and he used to work at the Bronx VA. He was a brilliant hematologist. He documented that on himself. Okay, so folic acid is very labile. When you are hemolyzing, you need folic acid to make new red cell. So the body is sucking up all the folic acid it can get a hold of to try to, in an attempt to try to keep the red cell production going. So therefore, all these folks are folate deficient. So you must give them large quantities of folic acid. I provide 4 milligrams of folic acid 4 times a day for these individuals, for my patients, all of them. Or people in other states that I manage them, still managing them on the telephone, they're doing fine. They have not been hospitalized. They're not getting pain medications. They're doing fine because I keep my hands on. They call me. I prescribe for them. I can prescribe. All doctors can prescribe in all states and territories. So I'm managing them long distance. Those who I'm managing locally, I have people in my practice that are in their 70s that have not been in the hospital for 10, 15 years. They're sicklers, and I'm taking care of them. So you give them the folic acid, 4 milligrams 4 times a day. What else do you do? Well, there's a medication called Hydroxyurea. It's a medication, it's a chemotherapy medication. It is used mostly in the treatment these days of people with polycythemia vera, even though we have newer medication for polycythemia vera that we use, but some places they're still using it because that's all they have access to, and it's still very good medication for that. I said, well, how do you go from sickle cell disease to hydroxyurea? Well, some smart person many, many years ago discovered that people who have taken hydroxyurea, they're able to stimulate hemoglobin F. Now, hemoglobin F is a fantastic oxygen carrier. That's the fetal hemoglobin that all of us human beings had in our mother's womb to survive, fetal hemoglobin. Once we born, the level of fetal hemoglobin started going down and down, down as we get older, okay, and so on and so forth. And we wind up with hemoglobin A1 and hemoglobin A2. However, it turns out that there's a place in the human body that still have ample amount of hemoglobin F. And you say, well, that place turns out to be the liver. All human liver still have storage of have hemoglobin F there. So the hydroxyurea stimulates the production of hemoglobin F from the liver, increasing the level of hemoglobin F in the bloodstream, making it easier for the person to carry oxygen, and therefore it has been documented, I've had it in my practice, that these individuals have less sickling attack. Their red blood cell level remains higher. They suffer less from painful crises, and they suffer less from hemolysis. And when they do hemolyze, they have that amount of hemoglobin F to help sustain them. Okay? So that's one thing that we do, hydroxyurea. So I have people on that. What else do we do? Well, there's another medication. It's called Procrit or Epogen. That's erythropoietin. Man-made erythropoietin is made in the kidney. Okay? So far, so good, in the kidney. So how do you go from sickle cell disease and the use of erythropoietin? Okay, well, this is academic medicine that I'm teaching you a few things. All individuals with sickle cell disease are hemolyzing. When they're hemolyzing, to one degree or another, they're dumping iron into the bloodstream. So far, so good. What does the iron do? The iron goes into the store. It develops secondary hemochromatosis. A high level of iron. You got primary hemochromatosis, which is a different disease. You have secondary. Secondary hemochromatosis is found in a multitude of different inflammatory type diseases, including people who are hemolyzing. Because by necessity, they have to dump the iron. When the red cell bursts, it has the iron in it, and the iron gets dumped into the bloodstream. The iron is extremely dangerous, very dangerous, because wherever the iron is loaded up, it has to, by necessity, degrade slowly. As the iron is degrading slowly, it is releasing material in the body that damages the body. Free radicals. The free radicals are very bad. Well, the iron is releasing them. Can't help it because the iron stays there, smack next to the tissue and the organ, be it the heart, be it the liver, be it the spleen, be it wherever. It's full of iron. The skin as well. So the free radical are causing damage. So what do? Well, you're going to use the iron to not only decrease it, you can't phlebotomize the patient. You can't remove blood from there. They're too anemic. So, but you want to use the same iron that are being dumped in the body that's hurting them. You want to use the iron to treat them, while at the same time decreasing the level of the iron. Well, how do you do that? Well, you do that by giving the patient Procrit or Epogen, man-made Procrit or Epogen, which is erythropoietin, man-made. How do we do that? How does the Procrit will work to decrease iron? Well, here's the deal. There's a protein in the circulation called transferrin. Transferrin protein. That's what transfers the iron from wherever it is in the body, carry it to the bone marrow to be incorporated in the baby red blood cell to produce red blood cell. Okay? And the pro-erythrocyte, we call them. Problem is, when you have that much iron on board, regardless the cause of the iron, it blocks the ability of the transferrin, the inflammatory process that the iron causes. In addition to the releasing of the free radicals that I talked about, it also causes an inflammation, very bad inflammation. That inflammatory process is preventing the transferrin protein from doing its job by blocking its ability to grab the iron and carry it. So the transferrin protein has finger-like things attached to it that can grab the iron, as it were. So, what do? Well, what the Procrit does, which is fascinating, it's amazing. What the Procrit does, let me give you, suppose you put a line right there, okay? There's a block. Here's the good part. This is where the iron is packing up over here, okay? And this is the threshold right here. So this transferrin protein cannot jump over here. What the Procrit does is that it forces the transferrin protein to grab the iron, as it were, and take it away. It pushes over. That's what it does. It pushes over the block. That's what the Procrit does. So you achieve two things. You are decreasing the level of the iron, okay, which is bad for the person, and you're also using that same iron to produce new red blood cell, because as the iron gets over the block, the iron is now free to go. Transferrin is free to do its thing. It's going to take the iron to where it's supposed to go, into the bone marrow to be incorporated into pro-erythrocyte for the production of mature red blood cell. How about that? This is extremely neat. Okay, so we use Procrit in people who have sickle cell disease, who have very high, all of them have very high serum ferritin, they have high iron. So that's another way of keeping the patients healthier, keeping them out of the hospital. You have this combination of stuff that we do, and I do, and others do. Let me repeat what we do. We prophylax them with antibiotics. We give them pneumovax vaccine. We give them folic acid in large quantity so that they can make more red blood cell. Okay, we give them hydroxyurea that increases the level of hemoglobin F. That's the fourth thing that we do. In addition to that, we use Procrit to increase the ability of the transferrin protein to carry iron across the threshold into the bone marrow. So we do that. So in addition to that, we're decreasing the level of the iron by using the same iron that is creating a negative situation to do a positive thing. And this is not just done in sicklers. It is done in somebody, let's say rheumatoid arthritis. Let's say somebody has rheumatoid arthritis. They're getting ready to go have surgery 2 months from now. Okay? They're going to be anemic because rheumatoid arthritis causes anemia because the iron, the inflammation, suppresses the ability of the bone marrow to make sufficient red cell through the same mechanism that I just explained. So what do you do for these people? 2 months ahead of time, you start treating them with Procreate. You assist them with Procreate, you're able to raise their level of red blood cell, then you send them to the blood bank to donate a unit of blood, sometimes 2 units, depending how far you start. And if they need blood during surgery, they use their own blood. Isn't that amazing? Isn't that amazing? This is people with rheumatoid arthritis that's going to have joint replacement. A few weeks before the surgery, we mobilize the red blood cell production by giving them Procrit or Epogen to the point where not only that they have enough hematocrit to be able to take anesthesia, they also can donate blood that's sitting in the blood bank waiting for them in case they need blood transfusion. Isn't that neat? All this stuff is being done. Listen, I'm going to stop here. I still have plenty more to talk to you about as it relates to sickle cell disease. Until I see you again, this is Dr. Alcena saying so long and bye-bye.